I suspect later this year we'll probably get the Keeper of Good Time Award, as we're starting almost on the dot of 2 o'clock. I welcome you all back, and I hope you've had an enjoyable lunch and that you're ready for this session, which I think is going to be demanding as well, because we had a demanding morning this morning with Owen Carolan telling us where Irish law is at the moment, and really explaining the complicated path our law has taken to get us where we are now. What we're going to deal with this afternoon is how the law is being applied in practice at the moment, which is of extreme importance in my view. And we'll first hear from Professor John Higgins from Cork University Maternity Hospital on the obstetric side of things. And then we'll hear from Professor Anthony McCarthy, who's a consultant psychiatrist in the National Maternity Hospital in Holles Street. And he's the clinical director in the Department of Psychiatry at St. Vincent's University Hospital. And both Professor Higgins and Professor McCarthy will talk about the circumstances in which a woman would present to a hospital requiring an abortion, and the process by which she could obtain one under the protection, under what I've been calling the Act of 1913, the Act of 2013. Sorry, slip of the tongue. So I'll call on Professor Higgins first.
Thank you very much indeed, and thank you for the privilege, I suppose, of being asked to speak to the Citizens' Assembly. You have a copy of my paper, I think, and the slides are really just a shortened version of that, and I'm going to in essence, try and use 3 cases to illustrate the task that I've been given, which was to explain what currently happens in Irish hospitals. And to a large extent, I think it's important to say it's what has always happened in Irish hospitals. The 3 cases I present, the first 2, in fact, would illustrate cases that we would see, not commonly, none of these cases are common, but they would have occurred essentially always, as long as we've been looking after pregnant women, and we've treated them in the same way. The 2013 Act probably put a legal framework on it, but in my experience, it hasn't actually changed the practice. So that's important. So, as you know, and you're probably much more expert than me now in the actual legalities of this situation and the law itself, but one of the things that the Act ensured was that the data around these types of complications and pregnancies were in fact available and submitted to the Minister, and that information is there, and you can see the summary from the first 2 years. So if you see the total number there, they're not big numbers in terms of Ireland's maternity services. Our birth rates are over 60,000 a year. So these are complicated, difficult cases, and I would say, if I can, that looking after women with complications such as these is one of the most challenging things we do professionally, but also from a personal point of view. And we have a lot of good research in Cork on the effects on the caregivers, the clinicians looking after complications like these, how difficult they are. So they're not easy cases. So I've said this, I think. The first 2 cases fall, if you go back to that Act, there's 3 sections that I think are pertinent, 7, 8 and 9, and 7 and 8 refer to conditions where the mother's life is in danger from a physical problem, we call it that, and 9 from the risk of suicide. And I suppose I would say that from our point of view, the mother's life being in danger, we would try not to actually differentiate between different types of risks, as long as the risk is real and bringing the pregnancy to an end is the treatment, we wouldn't differentiate between the conditions themselves. So let's look at the first clinical history. And this is these histories, by the way, they're not real people. They're all called Mary Murphy, which is not because I'm from Cork, but they're simply to make the point that they could be, though. And the stories that I'm telling here absolutely reflect real-life scenarios, but they're not of themselves real people, so they're very important to say that. So this first clinical history is a 33-year-old mother of two. She's booked to a local hospital. First two pregnancies completely uncomplicated. So really expectation is that everything will be great. That woman has a fantastic, if you look at what's her likely outcome is everything is going to be great. And unfortunately this time though, at 18 weeks gestation, so just what do we mean by that? Normal pregnancy is 40 weeks. And most people know that, but not everybody. So 18 weeks, that's very early. And she presents to the emergency room and she has noted that she is leaking clear fluid from her vagina. Now, that is something that doesn't happen often, but we would be it wouldn't be something that the staff would be surprised about, because they would immediately suspect that the membranes that surround the baby normally, that protect the fetus in the womb, that they have ruptured. And that's what, as the case, and you've probably read the case, that's exactly what transpires. So they examine her and they come to the conclusion, yes, the fluid around the fetus has in fact leaked away. So she's admitted to hospital, and that would be standard. And she's monitored very closely. She'd be monitored every 4 hours, particularly temperature and pulse. She has special blood tests done, they're taken regularly. And all the focus actually would be to ensure she's not developing an infection, because those membranes, that sac around the fetus, normally protect the fetus and allow it to develop normally, because they need fluid for normal limb development and so on, lung development, but actually they also protect from infection. As I've outlined in the case, 2 weeks later, the woman is still in hospital. So she's kept in hospital, she's been there, been monitored all that time. She goes to bed at night, she feels fine that night, she wakes up and she feels terrible. And her pulse is racing. She has a high temperature. And her blood pressure is low. She is in shock. So this poor woman has developed an infection in the womb called chorioamnitis, and is now, essentially her life is now in danger. She will be transferred immediately down to a high dependency unit, usually maternity hospital, that's in the labour ward. And the decision here, in fact, at that point, isn't one that we would agonise over. We would certainly have to, I suppose, explain to the woman exactly what's going to happen, but we would have been discussing it with her over the weeks, over the 2 weeks when she was in. And the decision here is reasonably straightforward. I'm just trying to explain it. Would we be unsure of the diagnosis? We wouldn't. And we wouldn't be unsure of the intervention required. And the intervention required would be that we would induce labour. Now, I noticed that Judge Lavoie mentioned the word abortion. That's not a word we would use very much. I'm just saying from the point of view of explanation, we wouldn't use that word very much in the hospital, nor would we almost never use the word termination to this patient. But technically, that is what we are doing. We are terminating the pregnancy. But the language and the discussion, while we are very clear what is going to happen, and she would know exactly what's being done, the terminology is important for us. And we wouldn't use the word termination, we wouldn't use the word abortion. So I've outlined a few questions and answers just to kind of illustrate the case more. What were the main causes of concern when Mary presented to the emergency room? Well, I've alluded to them. There's a long-term problem. As soon as the waters go that early, 18 weeks, there's a lot of things can happen now to that fetus in terms of development. But the more immediate or a medium-term concern within the pregnancy is that the mother is now at risk of infection, and if she does become infected, we will need to intervene as we have in this case. Of course, what we're hoping is that that doesn't happen for, some of the cases, of course, that wouldn't happen until 34 weeks or 32 weeks, and the outcome is very good for mother and baby. But in this case, because it's happened so early at 20 weeks when she eventually gets unwell, we know what the outcome will be. So what is the treatment when this infection takes hold? Well, she certainly would be given antibiotics intravenously, but the treatment once she has an established infection in the womb is delivery. And that really is the treatment regardless of the number of weeks the mother is. And we know, because question 3 says at 20 weeks and 1 day, what would be any hope that the baby is born alive, that it would survive? The answer is no. So we know that in advance. But we also know that both for the mother and the fetus, if we don't intervene, they most likely both will die. So question 4, what is the main cause of concern? Well, I've answered that already. I seem to be answering the questions in advance. Question 5, what are the main procedures and processes? Well, you probably all know the answer to that too. I won't ask you to answer it though, because you've been reading the Act. But in practical terms, for us, that would be two consultant obstetricians. And I know in the Act you need one obstetrician, but actually in someone with this disorder, you would have a second opinion from a consultant obstetrician. Both would confirm that this intervention was required, and then there's a notification requirement and so on in the Act. That scenario, as I said, has been occurring, forever, and we've been dealing with it in the same way. But the Act does provide a framework and a notification, which I think is helpful anyway. The second case, a little bit different, but again, and a rare thing, actually more rare than the first case, but almost a sentinel story for human pregnancy. All obstetricians would recognize the story. This disorder that I describe is the sine qua non of pregnancy and a complication of pregnancy. First-time mother, 42 years of age. So 42, that's quite common. If you think about that now, it's not what, we have a high rate of women over 40. So she's booked on her first pregnancy. So she'd be the focus of increased attention in the hospital because of that. But she's fit and well, but her family history is significant. Her mother's first pregnancy, that's not her, but her mother, was complicated by very early onset, she calls it toxemia. So she was, I think, the second pregnancy, as it were, that her mother had. Now, that would again make us think, that's unusual. We know it happens. It makes the mother, the patient we're looking after here, more at risk of toxemia. We'll give it its real name in a second. So at 19 weeks and 5 days, Mary attends her GP. She feels a little bit unwell, a bit agitated, a bit jittery, a strange feeling. And the GP, he checks her blood pressure, because he immediately that would bother him if that was the concern. And she's got very high blood pressure, and he checks her urine, which is the follow-on from that, and it's full of protein, and sends her straight into the emergency room. Now, 19 weeks and 5 days, very unusual to present like that, but it does happen. So this disorder usually occurs later on, but every so often we see a case like this very early on. And at the maternity hospital, she's had bloods taken and a range of investigations, and they show evidence that there's damage to her kidneys, to her liver, to her blood clotting system. She continues to feel unwell. She has a headache. She's admitted to a high dependency unit, again on the labour ward, and she's given a range of medications, particularly to try and lower her blood pressure and to prevent something that may happen in her, that is seizures. So this disorder we now call preeclampsia. It was classically called toxemia, and the population, or patients often refer to it as that. And if a mother fits subsequent to that has a seizure, we call it eclampsia. Both those disorders, both a fit, a seizure, or if the blood pressure is very high and she has a stroke, which is another distinct possibility, both of those can be associated obviously with maternal death. We also know that once we've made that diagnosis, and early onset cases we'd exclude other things, that the only treatment that really is effective is delivery. And it's not the baby that needs to be delivered, it's the placenta. The problem is the placenta. I know that's paradoxical, but that this disorder only happens when you have a placenta or an afterbirth. So, question 1, is this type of preeclampsia unusual? Yes, very unusual, but recognised. We know it exists. In a big hospital, we'll see this every few years. What would be the main cause of concern for Mary's well-being? Well, I mentioned that. 2 big things. 1, she can have a stroke. 2, she can have seizures, and both of those have a high mortality associated with them. Are there not medications one could use to treat this disorder? Well, we can help with the blood pressure. We can attempt to lower it. We can give medications to try and prevent seizures. But in this progressive disorder, it's inevitable that our treatments will fail. So it's only a question of how long we can put a brake on things. We can't reverse this disorder without intervention. And again, question 4, what are the main procedures and processes? They're very similar to the previous case. The difference, I think, in this one would be that we certainly would have got other opinions, I mentioned that, from other medical specialists, just to be sure it's not some other atypical disorder. There's a number of medical things that could mimic preeclampsia. So they would be involved, but usually the final decision would come down again to 2 obstetricians, 2 senior obstetricians, confirming and that the diagnosis is likely to be severe early onset preeclampsia. And then there's a discussion, which of course Mary would be involved in anyway from the start, and an intervention. And what I mentioned here was that 3 or 4 days afterwards, everything is returning to normal. So by and large, that you can absolutely cure this disorder. It doesn't continue to progress, it goes away. The last clinical history is, I suppose, very pertinent to the Act in the sense that it wouldn't have been as clear a component of our long-standing practice. And that relates to the area of suicide. And this is a case or history of a 28-year-old woman who's pregnant for the first time, long history of depression since her teens, and has been admitted several times. And she attends her GP at about 8 weeks. She thinks she's pregnant, and that's confirmed. But her GP, again, is very worried when he sees her. He thinks she's very low, concerned enough to ring directly to her psychiatrist who's been looking after her for the last 12 years. And she's seen a couple of days later, and a lot of the focus of Mary's depression, suicidal ideation, which she articulates, is around the pregnancy. So it's not just that she's depressed and she feels suicidal, she has a focus in terms of the pregnancy. And she's referred into the maternity hospital. She has a scan to confirm, it's very important to confirm that the pregnancy is ongoing. And she's then seen by a psychiatrist attached to the maternity hospital. He has a long consultation with her, and again concludes she's very depressed with suicidal ideation. And he believes that this places her life at significant risk, and contacts her consultant psychiatrist to discuss his concerns. And then the consultant obstetrician on call is asked to see her. In this case, I just mentioned that the consultant on call actually refers her to a second obstetrician, who then meets Mary, and a decision is made. In this case, and again, the terminology at 8 weeks is slightly different. It's interesting, but even in terms of explaining it to the patient what we're talking about doing at 8 weeks, it's hard to talk about delivery at that stage. So a termination is performed, and after the procedure, the mother is admitted to her local psychiatric hospital. I thought I wouldn't do my questions and answers because I know we're going to hear a more detailed discussion on that section of the Act, and I might just leave it there. And of course, I'm going to take questions and be available for the workshop.
Yes,
so thank you very much indeed.
Thank you.